can I just check that you can see that okay? Okay, so what I'd like to talk about is how to develop clinical services. And so you've heard yesterday, and you'll hear further today about specific types of treatment and so on. But I'm more in this talk trying to think about how could you organize a care pathway, a healthcare pathway for people with FND, and thinking about the opportunities that gives rise to, but also the problems that can arise as well. So this is some of the this is the sort of structure of my talk. So I was going to think about some of the facts of life that think about that we need to remember when developing treatment pathways, thinking about what evidence there is to support treatment pathway development, and then thinking about what the long-term legacy might be. So if we got this right for people with FND, how could that help everyone? So this is, I think, some of the basic facts of life of FND come down to how common it is. So this is a really common problem. It's similar in its sort of incidence to Parkinson's disease. It's a very common disorder, and it's very commonly seen in neurological practice. So about 15% of consultations in neurology outpatients, in hyperacute stroke services in the UK and the US. So that's services for thrombolysis, thrombectomy. About 10% of all people who go into those have a functional disorder, not a stroke. It's very, very common in the emergency room. So people who frequently attend the emergency room, most of them or a lot of them have functional neurological disorder. And it's also really, really common. They're really, really costly. So the costs are similar to people with severe neurological disease. And when you look at what the money is being spent on, the money is generally being spent on admission costs and acute investigations, often re-investigations, so having your 17th MRI scan, for example. So most of the costs don't relate to anything that you or I would think about being therapeutic for people with FND. So there's some other facts of life as well, beyond how common it is, that should shape the structure of any service. So the first thing is it takes time to create diagnostic understanding. And that's not because patients are stupid or difficult. It's just conceptually a difficult diagnosis to explain. And FND itself, in my opinion, is a general marker of complexity. So what I mean by that is that when somebody has an FND diagnosis, it's highly likely that their medical, psychiatric, and social circumstances are also going to be complicated. So that means that not only is the diagnosis itself a complicated thing to explain and understand, there's often lots of other stuff going on around. It's also the case that patients are very different one from another. They also present to multiple different services, including emergency services. And also for many people, unfortunately, it's a chronic disease. So let's just think a little bit about what goes wrong in diagnostic explanation. So if you type neurologist and patient into Google Images, this is one of the first things that comes up. And for me, it tells me everything that's wrong about modern medicine, because we know this man has a bad headache, not because he's holding his head and saying his head is sore, but because his brain is red on a scan. But anyway, the typical approach is to tell people what they don't have. And these things are true. So, you know, you haven't had a stroke, you haven't got MS, that's truthful, but it's not telling people what's actually wrong. And this gives people the impression that they're very complicated, and give doctors the impression that people are very complicated. And you can do even more complicated tests. At some point, somebody is going to be sort of brave enough to have the big talk with the patient, and they're going to say something like this. But for any person walking down the street, not a person with FND, but for any person, this statement generally means this. So it means, so you think I'm making up my symptoms. So people get annoyed and angry, and they go and see more doctors. Now, sometimes people will go and see a psychiatrist. This is what Google Images thinks psychiatrists and patients look like. But often a psychiatrist might say this, particularly if they don't know much about FND, because they're looking for things which they think are the cause of FND, particularly trauma. And sometimes those things aren't there, or they're not very prominent. And by the time the patient's got to see a psychiatrist, they've developed a whole load of new neurological symptoms, which the psychiatrist then can't deal with and needs to send them back into neurology. And maybe the patient will go for some sort of treatment, maybe a psychological treatment, maybe even some inpatient treatment. But it doesn't change the fundamental state of this person within healthcare. So this is a picture by a famous artist called Hieronymus Bosch of limbo, which is just above the 7 circles of hell. So it's still not a very nice place to be. And this is my impression of what it's like to be a patient with FND in healthcare, because you're not really anywhere. You're not doctorable, because you don't have a thing that's owned in any way by a health professional. And that's a really difficult situation to be in. So my general advice when it comes to delivering the diagnosis is just to be normal. There's lots and lots of papers about this. This is one of my favorites from John Stone and Alan Carson, which is in the sort of form of a picture story. So the basic idea is that if you're normal, if you give the diagnosis in the way that you give any other diagnosis, then it tends to go much better. And the key bit of that is to start with explaining how you've made the diagnosis, not why. And if you think about it, that's how we go about explanation of all diagnoses, really. We explain to people how we've come to the diagnosis. And then we might talk about risk factors and comorbidities and the complex reasons why things happen, but not at the beginning. So if I was explaining something, a diagnosis of functional weakness to somebody, I'd say, well, you have functional weakness. That's a common problem. I see it all the time. It's a real thing. It's not made up. It's not all in your mind. But it's a different thing than having a neurological disease process. And let me explain why. So I know your leg was weak and you were trying to move your leg, and I could feel that there wasn't much movement there. But then I triggered that movement in a different way by getting you to lift up at the other leg. And then I felt your weak leg come back to life briefly. Now, what that says to me is that the basic wiring of your nervous system is okay, and you're trying as hard as you can, but you can't connect the two things. So you can't access or control your body normally, even though you're trying and even though the wiring's all okay. And that's what a functional disorder is. So with that kind of explanation, most people, it makes sense to most people. And then it's much easier to get into the reasons why. And then there's a lot of work to do to understand the heterogeneity there too. And this does take time, but I think that's okay. So I put these 2 pictures up of a pituitary tumor and somebody's carpal tunnel to illustrate the point that you wouldn't expect a neurosurgeon to spend the same amount of time treating somebody's carpal tunnel as you would for them to take out somebody's pituitary tumor, because one thing is much harder than the other. It's much more complicated than the other. But for some reason in neurological and psychiatric consultations, we have a sort of set appointment time usually for a particular patient. And that's not right, because this just takes more time. But it's not mysterious and it can be taught. It's not really very different from other diagnostic communication. And it needs to be started by the neurologist, but it can be elaborated, continued by other members of the team. So neurologists, I think, have to be a key part of initial diagnostic delivery at the very least, because it's reasonable for somebody with neurological symptoms to receive a diagnostic explanation from a neurologist. It shouldn't be a neurologist saying, this is not neurological, go and see somebody else, because that's just not reasonable. It's not a reasonable way to behave. So there's some really good resources out there, and you could think, well, if we kind of were better at doing diagnostic explanation and then we kind of give some people some education, some information, maybe that's what we need. That's our pathway. That's our service pathway. So we know that that's not true. So there was a very nice randomized study done where John Stone's fantastic website, which is translated into multiple languages, this is neurosymptoms.org, if you've never come across it, that was delivered in a randomized fashion to people just diagnosed with functional neurological disorder. So some people got the website, some people didn't get the website. And there was no difference found in outcomes. What the difference was that all of the patients who had the website said it was fantastically useful. They felt much more informed. It helped their relatives. And they would recommend it to other people. So it was really useful, but it didn't magically fix them. And we shouldn't really expect that something like giving a website should. And so this is an excerpt from a tweet from one of the functional neurological disorder charities of a doctor scribbling on somebody's newspaper by the side of their hospital bed, neurosymptoms.org, and saying, you know, this is what many doctors see as the only treatment needed. And I've had many patients say that to me. Oh, the doctor gave me a website and told me to go away. So it's useful. The information's out there. Neurosymptoms.org and other websites are fantastic resources. I definitely recommend them to you, giving them to your patients, but it's not enough. That's not a complete pathway. So in order to think about a bit more about a pathway, we need to deal with this issue about heterogeneity, because people are very different one from another with FND. And I've divided this heterogeneity into three different sort of categories: heterogeneity at the level of symptoms, heterogeneity at the level of comorbidities, and then the sort of psychosocial heterogeneity. So thinking about the symptom level, people have different severities of symptoms, and that should be expected. We see that in all illnesses, but it does impact on what you should do. So if you have a pathway, it's reasonable that there should be a way of stepping up quickly to a sort of high intensity specialized treatment right away. So there's sometimes an idea in treatment pathways, which is sometimes called stepped care. And that means that you get a diagnosis and you start at step 1 and you do something. Hopefully you get better, but if you don't, then you go to step 2. Then if you don't get better, you go to step 3 and so on. But this is a bit stupid if you think about it, because we know that some people, particularly with high severity, are not going to do well with lower level treatments. So instead of stepped care, what we really need is something called stratified care. So that means you can jump to higher levels if needed. So there are differences in the way in symptomatic treatments, in treatments devoted to the symptoms. There are differences if you have motor symptoms, if you have sensory symptoms, if you have seizures. So there are, so we do need to have some specialization within the pathway that might say, well, people with motor symptoms, it's likely that neurophysiotherapy is going to be an important part, maybe sometimes even the only part of their treatment. Whereas for people with seizures, it's more likely that a psychological treatment is going to be front and center. And then lastly, there's the symptoms that very, very commonly go together with functional motor, sensory, and seizure symptoms, which is pain, fatigue, and cognitive symptoms. So these are part and parcel of FND, but they are important to think about, and that's for this reason. So when people have looked at quality of life in people with functional neurological disorder, and they've correlated that with different symptoms, it's these things of pain, fatigue, cognitive disturbance, which are the things that really drive symptoms, really drive quality of life, as well as mood as well, so depression as well. So they're the strongest predictors. So we need to incorporate these into our treatments, and we need to be sensitive to them. And there's one particular bit of advice which I'd like to share with you, which is that there are some people, so to start that again, there are, when you see people with FND, almost all of them will report pain and fatigue and cognitive symptoms. But then there's a group of people who have what I would call very irritable pain and fatigue. And what that means is that when they do things physically or cognitively, and how are you going to feel tomorrow? And if people say, oh, you know, I'm going to be a bit tired, but then the day I'll be okay, that's fine. If somebody says I'm going to be in bed for a couple of weeks, then that gives me So let's think about comorbidities now. So I'm going to talk a bit about overlay, functional overlay, and prodrome, and then an important issue around labeling, particularly as this label of FND becomes more and more used. So overlay is really common. So what I'm talking about here is where people have functional neurological disorder and they also have another condition. So this graph is from work done again by John Stone and Alan Carson in Edinburgh, where there's about 4,000 patients included here who have neurological diseases of different sorts, so epilepsy, MS, Parkinson's disease, and so on. And across the board, about 50 plot of rest tremor on the left there. But you'll see in a minute why he came seeking DBS, because he had a medication refractory tremor, which was this. So they increased his Parkinson's medicine, didn't make any difference. And you'll see in a minute why, because this is a functional tremor. So when he's distracted, just by giving him instructions there, the tremor's completely stopped. So it's really important in being able to manage people effectively to understand this, this overlay. And that's the commonest diagnostic error that I see, is when people have recognized the functional neurological disorder, but they haven't recognized the other conditions that are there. There's an even more complicated issue, which is around prodromal FNDs. So I've seen many patients, and lots of people have been reported in the literature, where a definite diagnosis, a clinically definite diagnosis of functional neurological disorder is made, but then a little while later, the person develops another disorder. So it's not that the diagnosis was incorrect, it's that it was prodromal. So for example, in this study from Alberto Espe, they looked at patients who had functional neurological disorder and Parkinson's disease. And there were a group of people, so about 20% in this cohort, who had FND before they developed the Parkinson's disease. So sometimes a couple of years or a year or so before. So this is a really important message, that you need to continue to follow up people with FND, and you need to be reactive to new symptoms. Don't just assume that they're part of the FND. You need to look at them in a reasonable clinical way. Then I think that what I've noticed more and more nowadays is that with this development of FND as a diagnosis, particularly amongst neurologists, there's this idea that it sort of catches everything. Oh, you've got FND, that's it. But FND, like I was saying yesterday, is really a diagnosis for the thing that we diagnose in a more neurological examination. And it's really it's basically the proximal mechanism for producing the physical signs and some of the symptoms that people experience. But actually working out what you're going to do with somebody needs much, much more than that. And so it's really not a complete diagnosis. And here's just some examples of that. There could be many more. So, for example, you would know that people with schizophrenia often present with, often experience physical symptoms, sensory symptoms, motor symptoms, and so on. Some people do have FND, but really the problem is OCD, or it's anxiety or post-traumatic stress disorder. It's becoming very clear that people with FND quite commonly also have neurodevelopmental disorders like autism or ADHD, and those can sometimes be the main drivers of symptoms. Some people, they may have some physical symptoms and signs, but really what they have is health anxiety. And other people even have a sort of monosymptomatic, psychotic, delusional state, rather, about their health, which drives symptoms. So we shouldn't stop thinking as soon as the FND diagnosis is made. And in the end, what we're trying to do is produce a good formulation. So back to key psychological concept of providing a narrative formulation for the whole thing. And that takes time. It often benefits from multiple perspectives, from family members, other health professionals, and so on. But that's really the key to working out what to do. And then lastly, just thinking at the psychosocial level, there are things that just make treatment really difficult. And unless you identify those things with a good formulation, it's going to be very difficult to decide what to do. So some people just have incredibly fixed beliefs that make rehabilitation treatment nonsensical. So if somebody believes that they have chronic Lyme disease, then me saying to them that I think you should have some physiotherapy or you should see a psychologist just doesn't make any sense. So until you change that health belief, there's no point in doing those things. Obviously, changing health beliefs is difficult, and it doesn't necessarily have to happen the first time. But after a period of time, if those barriers are in place, then it's reasonable to communicate your diagnosis clearly in a non-judgmental way and leave the door open for coming back again. And that's part of the reason why treatments, when I'm offering treatments, I would always offer them in an opt-in way. So I'd say, we have these treatments, this is what they can do, this is what they can't do. Have a think about it and let me know what you'd like to do. Rather than saying, we've got this treatment and I think you should do it. Because it has to have this beginnings of patient autonomy and choice within that, not just being told what to do. And there are things like being in a medical legal situation, being in a very, very complicated employment situation, having difficulties with housing. These are all things that make rehabilitation very difficult, and you need to know about them. And not everyone is treatable in the end. And there's a difference between saying to people, you know, I can't treat you at the moment, but I'd like to continue to support you, and saying there's no treatment and I never want to see you again. So offering people ongoing support is really critical. And just to illustrate that a little bit, this is a study that I was involved in, a randomized study, which has now gone to a multi-center clinical trial of a specific physiotherapy program for people with functional motor symptoms. So we randomized people to receive specialist physiotherapy, really guided by a better conceptual understanding of functional neurological disorder. So this is our results. So we found in the intervention group that 70% of people reported a good outcome compared to 20% in the control group. We halved their healthcare costs over 6 months. And like I said, it's part of a randomized trial now. So, and this is a patient going through that. This lady had abdominal surgery a couple of years before, got into a lot of pain, and then developed a significant gait disturbance. She's largely wheelchair dependent. She's been asked to walk to this line on the floor. I just want you to see what happens when she gets there and turns around. So just there, she has 2 or 3 normal steps. So this video is not being taken to catch her out. It's being taken to show to her and her partner that what's happening there is her attention is being distracted, and she's able to access normal automatic movement. So this is her a couple of days later, practicing dancing, not walking, not thinking about walking. She's thinking about sidestepping, and it's all much easier. This is her after 5 days of treatment. So you might think, wow, you know, physiotherapy, that's the treatment for it. If I see somebody with functional motor symptoms, they're going to have physiotherapy. That's all they need. But that's not true, because in order to get those 60 patients we randomized for this study, we screened 210 patients and rejected 2/3 of patients for a variety of different reasons, like irritable pain, irritable fatigue, psychiatric problems that hadn't been treated, and so on. And I'm sure if we put all of those patients into that trial, it would have been negative. So you really need to triage people, and that involves a collective hive mind in some way. You need a collective of health professionals looking at things from different angles to make the best decision. So that's a rather long introduction, but just to move on now to think about treatment pathway development. So treatment pathways currently for people with FND usually start in a very normal way. So a patient goes to a doctor saying there's something neurologically wrong. And that doctor does a normal thing depending on the urgency and the severity of symptoms, in that they refer them to an emergency room, to a stroke unit, to an outpatient neurology clinic. But then weird things start to happen. So in those initial contacts, sometimes the diagnosis isn't made at all. Quite often the diagnosis is made, but then it's not explained at all, or explained in a way which alienates the patient. Then the staff there don't really know what to do. They don't feel they have the skills and knowledge. They may have negative attitudes, often built up from really not knowing what to do. It's a difficult situation, and they don't really know where to refer people to. And there's actually lots of potential places these patients could go if the services are available, to psychiatry, to a psychology service, to a pain service, a fatigue service, etc. But there's no stratification there. So which patient turns up in which service is pretty random. And those services tend not to talk to one another. So if the patient turns up in a service which is not appropriate for them, or they have treatment and it doesn't work, then the patient's sort of nowhere. They don't know what to do. So actually you have enormous money being spent and enormous activity, but the patients are very dissatisfied and they're often alienated and stigmatized. So we do know some things that we can do. So we can try and make education better. So this is some papers about self-help and education. So this is the one on the left is about running an education service. So that's something that I do for all newly diagnosed patients. They get invited to an online education session, which happens once a month, where there's a neurologist, psychiatrist, physiotherapist, psychologist, there's a patient who's had a good outcome with treatment, and they have a presentation about what FND is. We do have evidence around the, at the other end of things, doing intensive multidisciplinary treatment, even as an inpatient, and that can work. We also have evidence around what therapists can do. So there's papers now, mainly consensus recommendations of what a physiotherapist might do, what an occupational therapist might do, a psychologist, a speech and language therapist, and so on. But the thing that's missing is actually putting that together into a service. So if you are designing a perfect service, you would start with this personal and systemic understanding of all of the diagnoses, not just the FND, but all of the other stuff as well. You'd triage people effectively according to their symptoms and comorbidities. They'd have some relevant treatments, and then there would be some kind of follow-up and follow-on of these patients, understanding that lots of people have long-term symptoms. So there have been publications around this, and just to start with some of the older ones. So this is one from John Stone, which is called stepped care, which I said was not a good thing. In fact, the diagram shows it's actually stratified care. So this is an idea that patients come to see a neurologist, that there might be a brief intervention which you can access, and then there's more complex care. The other paper there is looking at how specialist assessment clinics run, and there's been these are clinics in the UK, in Switzerland, and in Canada, just sharing some experience of what it's like to run a specialist assessment clinic and the pitfalls of that. And then this is something which I've been involved in the UK, which has been through national patient and healthcare consultation, which is what's called an optimum clinical pathway. So this is part of a series of pathways being developed in the UK, mainly in neurology, which are trying to lay out what a good clinical pathway would look like. This
okay, I found this on the web for a series of...
That was Siri. This pathway, which you can look at this email address here, this web address here, it lays out a structure for how you might be able to run a pathway. And it's, to be honest, even though the diagram's quite busy, it is quite simple about how people can go through from primary to secondary to more specialist care and back again, and how services interact. So these are just some examples from that about how diagnosis should be made, the fact that this is the responsibility of the neurologist when they're referred into neurology, that emergency departments and so on also need to have expertise, and that when there's diagnostic uncertainty or when there's high symptom levels, then there needs to be some specialist service. And that there's some integration between different services so that a person can step up and step down between parts of the healthcare system depending on the severity of their symptoms. And that there should be the development of a specialized service which can sit on top of all of that, which would have additional things it could do in terms of diagnostics, and also different things it could do in terms of treatment. And that needs to interact with other services, in particular in mental health. So I've gone through those quickly, but you could look at them. But I think it's hopefully a useful document because it's something relatively official, which we can use to say, well, there should at least be a service, and it should have these basic components. And just to share what I do where I work at King's, so this is the service which we're in the process of establishing. It's not fully established yet, where all of the patients who get a diagnosis of functional neurological disorder living in our catchment area, they get invited to an education group, which I've discussed online, and then they come to a specialist assessment clinic within about 6 weeks. And that a clinic which is largely neurology-led, but supported by psychiatry and therapies, tries to make some reasonable triage decisions. And it triages people into community services, so community rehab. This service, IAPT, is a primary care psychology service. That's community mental health trusts as well. So you're triaging into those services. But at the same time, the specialist services offering training and support to those community services, which are non-specialist. So it's trying to skill up people there. And it also provides a multidisciplinary meeting for people to bring cases to where they can be discussed. Then we might triage people into outpatient specialist services like physio, cognitive behavioral therapy, and pain and fatigue services. And then there's a group of people who've got complex symptoms where we would be filtering them into more complex specialist rehabilitation, either as a day patient or an inpatient. But there's a very important bit in there, which is this extended virtual multidisciplinary assessment. So what that's trying to get at is that after a assessment, there are a group of people who look like they're suitable for rehabilitation, but they are really complicated. And it's hard to make a decision right away. And rather than just send them into a waiting list for an inpatient rehab or something like that, we've found that it can be useful to just spend a little bit of time, a few weeks, with a few therapy sessions, maybe done virtually, just to get a little bit of better understanding of the patient and basically to establish their readiness for rehabilitation. So are there fundamental barriers that would stop this person participating? Are there diagnoses which haven't been made at the initial assessment, particularly around personality disorder, that would mean that a different kind of treatment might be helpful? So because inpatient and specialist rehabilitation is always going to be a very limited and valuable resource, it's important to make sure that the right patients turn up there. So this extended multidisciplinary assessment done virtually is really helpful. It can be hard to make the case to funders because at the moment there's not very much evidence that putting in place a pathway will save money. And that's because nobody's ever been able to put in place a pathway. There's lots of evidence that FND is really expensive and that what we do now is really illogical and expensive. And there is growing evidence for the benefit of treatment, but there's not that many randomized studies yet. We do know that, however, that the longer it takes for people to get to treatment, the worse their outcome. So I've found that in addition to saying that it's really expensive and that we do have some effective treatments, you can make successful arguments on the basis of equality, because people with functional neurological disorder clearly have significant and disabling long-term symptoms, and yet they have very, very poor access to any sort of treatment. So I think there's a very important equality argument there. And that can be helped if you develop patient organizations or patient charities that can lobby funders. And also amongst colleagues, people, health professionals in general, don't like dealing with people with FND. They find them difficult. And by setting up a service, you can solve problems for lots of people, like in the emergency department, in acute medicine and so on. And so that can be a way to get support from your colleagues for services. So just in the last minute or two, just to think about what it would be like if we actually got this right. So there's a pervasive, really pervasive idea in medicine that things that people tell us in a consultation, things that people might fill out on a quality of life form, the level of disability that somebody might have, is directly and in a linear way correlated to something that we can find within the body. And over time, we got better and better and better at looking inside the body at a more and more microscopic level. But this idea is just completely untrue. So when you look at any chronic illness, the level of symptoms people have, their quality of life and their level of disability are very poorly correlated with measurements of disease activity. So for example, if you take chronic airways disease, and you measure people's lung function, that correlates very poorly with their level of function in real life, their quality of life, their disability and symptoms. Similarly with ischemic heart disease, similarly with MS. So, and that shouldn't come as a surprise, given what we've been talking about and you heard about yesterday, because the sort of your lived experience, if you like, of illness is related to stuff going on inside the body at a disease level. That's absolutely true. And that has its own biopsychosocial aspects to it as well. But there's an important bit in the middle, which we could talk about as a sort of psychosomatic interface. So that has its own biology, its own psychosocial aspects. And it's the combination of those two things, the disease and the psychosomatic interface, which end up with what it's like to be ill. And that's how being ill is different from having a disease. And the problem is that most healthcare is relating to having a disease. It's not about how to help people who are ill. So the idea would be that if we got this right, if we were able to improve healthcare systems to manage illness for people with functional neurological disorder, you'd realize that actually that same structure would be fantastic for helping these sorts of problems in people who have an underlying disease as well. So that means that in theory, the legacy of developing better services and understanding and better treatments for people with FND would be that we're able to deal with one of the major sources of disability for people who are ill with other problems, because this psychosomatic interface is so important for a large group of people in magnifying symptoms, disability, and impaired quality of life. So I hope that was helpful and interesting, and I'd be happy to take any questions.